to explain the surgical orthodontic and envelope of discrepancy, you just got to know what is the limit for orthodontic, and if you're outside the limit orthodontic, then maybe have to go for surgical options. Then you should be able to explain the major order surgical procedure. Wait. Sorry. Can you hear me? Can you hear me?
I can, but it's very soft.
Very soft. Sorry. Just 1 second. Just let me quit scoop first. Okay. All right. Any better?
Yes, better.
Okay. So explain the major order surgical procedure in relation to the orthodontic. Usually it's orthodontic surgery. Then explain the diagnosis and treatment planning for surgical orthodontic. So we can go through step by step how to plan the surgical case for orthodontic. So what's the content? It's the etiology of dental facial deformity, then how this happened. Then if this happened, then how we're going to deal with that. Orthodontic surgical procedure, be it minor or major. Minor one can be a precision or any gum surgery, or any phrenectomy, the removal of the wisdom tooth or any tooth to be removed to get the space. Major one can be the jaw surgery, can be upper jaw, lower jaw, and can be Bimax. So envelope of discrepancy, then like I say, what is the scope for orthodontic? Then outside the limit, then maybe consider surgery. So there's a limit how much you can move the teeth up, down, forward, backward. That's the limit for orthodontic. You have to know that. Then the step involved in orthodontic surgery, step by step, how we plan for orthodontic surgery. Then the surgical option for maxilla corrections. Then the option for mandible corrections. So maxilla can do impaction, advancement. Same for the mandible, you can do advancement, then can step back, then bring it up, down. That's a surgical option. So what's the learning outcome? You should be able to explain the surgical orthodontic and the envelope of discrepancy. What's the limit for orthodontic? Then what's the limit for surgery? Then explain the major order surgery procedure in relation to orthodontic. This one can be surgery or the upper, lower, or Bimax. Explain the diagnosis and treatment planning in surgical orthodontic. So what is surgical orthodontic? So it denotes a surgical procedure that's carried out before, during, and after active orthodontic treatment. So the surgical procedure can prevent or correct the periodontal problem, facilitate and hasten the orthodontic treatment. It can assist, or it can fasten the orthodontic treatment, or reduce the relapse and the post-orthodontic stability and improve the aesthetic and function of the patient. So whatever help for braces treatment, then the surgical procedure can help, then we can do it. Be it before, during, or after the active orthodontic treatment. So what's the etiology? What's the cause for this dental facial deformity? It can be prenatal, immediately born, or it can be after born. What's the specific cause? It can be fetal. So too much power. Periodontal is a treatment for this epilepsy, then have facial cross. After the surgeon golden mandibular facial dysostosis, again, facial clefting syndrome, cleft lip and palate. A controversial, this one is due to warpism, then this one is failure to replace the replace then associated symptoms, fusion of the skull early, then Pierre-Robin symptom usually associated with the cleft lip and palate. So postnatal cause after the baby born is injury to the nasal septum, injury to the condyle, injury to the ramus, whatever cause trauma to the developing structures, then can cause the facial deformity. Injury to the alveolar bone and teeth can be trauma, then can be any other reason. Missing muscle, then can cause a facial asymmetry also. Condylar hyperplasia, again, one side grow more than the other side, can cause facial asymmetry. Hereditary means that inherit from the patients. parents, mandibular polynism, very common, castry patients, usually genetic. You see the patient have the long facial mandible, then you look at the parents, then a lot of time, either on the mother's side or the father's side, have long face also. Environmental can be posture. Posture means the patient is not standing straight for many, many years, then they have a humpback, and then maybe a cause of facial asymmetry. And it can be respiratory influence, the airway. A lot of people say if you breathe through your nose, then usually you have a better face. Then if you breathe through your mouth, then you usually have a long face, or they call adenophasia. So sometimes people have the respiratory problem or airway problem, then the best person to see is the ENT surgeon to rule out any airway problem when they are still young. When they are already fixed, grow up, then maybe it's not much can do. Well, it's a minor surgical procedure can help orthodontic treatment. So it can be extractions. So a lot of time we do the extraction to gain the space. So therapeutic extractions, serial extractions, extraction of the caries tree, malformity, then supernumerary. Malformity can be direct serrated. Supernumerary, what's very extra. Impacted teeth can be canine, premolar, whatever comes last and usually impacted. Second, it can be surgical uncovering the teeth. So a lot of time the impacted teeth, like canine, we can do surgical exposure and bone, and then try to drag the teeth out. Frenectomy can be due to this frenum is too low, then it's blocking the teeth from coming together. Then we can cut the frenum and then bring the teeth together. So you can see on this top right corner, there's a picture. Then there's a frenectomy. After frenectomy, you can bring the teeth together. Then precision, then usually is for the last snap after you correct the severe rotations. Then you cut around the structure, supporting structure. We require to cut away the recombinant periodontiums surrounding the tooth. Then by doing that, then usually they say more stable for the correction of rotations. Transplantation of the teeth, I don't do it very often because this is very surgical technique sensitive. So a lot of surgeons prefer not to do it because you need a very precise transplantation. If you're not careful, then the tooth will end up in necrosis bone. So when they transplant the tooth, they're very precise, then they have to do a 3D scanning then before transplant the tooth. Corticotomy, then you can see this top right corner, the bottom one. Then there's what called the corticotomy. The reason why they're doing that is to create whatever trauma to the bone, then the bone turnover will be faster. Then that's how we move the teeth a bit faster. So you create the trauma, then you create the inflammations, then the turnover, bone turnover, reformations, so regenerations, then be faster. That's how the teeth move faster. Of course, you cannot do it too often. Then this one heal up after 3 months. Then a lot of times they do the second procedure. So every time you want to fasten the teeth movement, then you have to do it again after 3 months. So I think it's not the ideal option. So major surgical procedure can be orthodontic surgery. Orthodontic surgery means you cut the upper jaw and lower jaw and move it around, then you get better proportions. Cosmetic surgery can be genoplasty, can make the chin longer, make chin shorter. Then surgical correction in cleft and palate patient. This is very common. We repair the lips and repair the palate when they come to the right age. Surgical assisted rapid maxillary expansion, we call it SAPI. So this one you can cut the middle palatal sutures and they cut the zygomates a little bit. Then you can expand the jaw a bit better. So a lot of time is because the palatal suture is fused after 10 years old. So when you want to expand the sutures, then it's a bit difficult. So you cut the sutures, then split the bone a little bit, so you can expand the jaw a bit better. So now we come to the envelopes of the discrepancy. What's the limitation for orthodontic treatment? So there are 3 possibilities of treatment: 2 movement by orthodontic treatment, then combination by orthodontic treatment, then the growth modifications. And the last one is by surgery. So you can see on this bottom right corner pictures. So the inner circles is by orthodontic treatment only. So you can move the teeth very limited. Up, down, forward, downward, very limited. Then you can do the other second envelope, which is by modification, jaw modifications, growth modifications, and orthodontic treatment only. Then the third envelope, which is the bigger circles, this one is by surgery. So surgery can move the teeth up, down, forward, downward, a bit better, more than 10 millimeters. So maxilla, the first envelope shows the amount of change that could produce by orthodontic treatment alone. So in vertical plane now, so you see this one, the first envelope. Can you see my mouse? Yeah, can you see my mouse?
Can, doctor.
Okay, okay. So you see first envelope, this one up is 4 millimeters, down is 2 millimeters. So you can see this arrow on the left side and the bottom left also. So this is how they move the teeth. Huh? So this one move the teeth down, this one move the teeth up. So for the maxilla incisal, so it means 4 millimeter, you can extrude the teeth 4 millimeters by orthodontic. Then 2 millimeters, it means you can intrude the teeth 2 millimeters. That's the scope for orthodontic. So in vertical plane, the space, there's more potential for the extrusion than intrusion. So extrusion, you can do 4 millimeters. The intrusion, you can do 2 millimeters by orthodontic. So anterior posterior plane of the space, 7 millimeter retraction. Huh? Same things. You see this in the circles. 7 retractions. The teeth can move backwards 7 millimeters by orthodontic alone. Teeth 7 millimeters back and move the teeth forward 2 millimeters. So the second envelopes of discrepancy indicate the change of teeth movement can be achieved orthodontically along with the growth modifications. It means you can combine the braces and then plus a bit of growth modification, either functional headgear or chin cap via jaw modifications appliance. So in the vertical plane of the space, 6 millimeter intrusions. So if you plus a headgear, maybe you can intrude the teeth 6 meters. So, sorry, 6 meter extrusion. So this one maybe with the face mask, you can extrude the teeth another 2 millimeters more. Then 5 millimeter intrusion, maybe with the headgear, then maybe you can intrude another 3 millimeter extra compared to orthodontic treatment only. So anterior posterior plane, 12 millimeter retraction and 5 millimeter proclinations. Further, plus the functional, maybe you can reduce another 5 millimeter overjet. And plus the the reverse spool headgear, then maybe you can achieve another 3 millimeter extra proclinations for the upper incisor. So with this modification, jaw modifications appliance, maybe you can achieve more than orthodontic treatment alone. So the third envelope, which is the outermost circles, then the changes can be achieved by orthodontic surgery. Also surgery, they move the teeth in millimeters, in centimeters. So a lot of time we say orthodontic, we move the teeth in 1 millimeter. Surgery, they move the teeth in 1 centimeter. Then periodontal, we are talking about 0.1 millimeters. That's how we differentiate the three different specialty. So the periodontists look at this 0.1 millimeters, very happy. But braces specialists, we look at the 1 millimeter movement. Then the surgeon, they look at the 10 millimeters movement. That's how we differentiate each other. So in vertical plane, you can see the vertical plane. So you see the outermost circles. So you can move the teeth 10 millimeters extrusion, and then you can intrude the teeth 15 millimeters. That's how much you can do it with surgery, with the maxillary impaction. So in the anterior posterior plane of the space, 10 millimeters advancement. So you can move the teeth forward 10 millimeters, and you can set back class 2. Class 2 set back 15 millimeters. That's a lot. That's a lot, 15 millimeters. So the mandible, in a similar way for mandible, in the first envelope, let's see this first envelope. I think the case note I sent you, there's some mistake. I think you just correct it. So this one, the envelope, first envelope, it can be achieved by orthodontic alone only. It means there are 4 millimeters intrusions, then 2 millimeter extrusion. You see the movement on the top and the bottom left. This arrow is how the teeth move the teeth. This one stand at the top, this one moving forward, and this one moving backward. So we can intrude the teeth 4 millimeters, and then extrude the teeth 2 millimeters by braces alone. So in the anterior posterior direction, there are 5 millimeter proclinations. You can bring the teeth procline 5 millimeters by orthodontic, and then 3 millimeter retractions for the mandible. Why the mandible is less than the upper maxilla? That's because we have a very thin mandible. So mandible, there's a limitation, how much you can move the teeth backward and forward, because the mandible is very thin. Compared to maxilla, you can move the teeth 7 millimeters and 2 millimeters, because the maxilla is pretty thicker. So you see the braces treatment, the bone or the maxilla and mandible, the jaw is the limitation for braces movement. You cannot move the teeth out from the bone. That's dangerous. The teeth might die then the fenestrations or the gum recessions. So the second envelopes, where the two movement can be achieved by orthodontic treatment combined with the jaw modifications. Again, the headgear, face mask, that's a considered jaw modification treatment. So it shows that there's a 5mm extrusion. You can extrude the teeth 5mm, and then you can intrude the teeth another 6mm. So a bit more compared to orthodontic alone. The anterior procedure, then you can achieve 10mm proclinations, and then 5mm retractions. That's a second envelope, second circus. So third envelope again is surgery. Surgery can move the teeth more than 10mm. So in vertical plane, you see the 10mm extrusion. Then you can do, intrusions, 10mm down, and then extrusion, 15mm. This can be done by surgery. The anterior posterior plan, there are 25mm of setback, 25mm. 2.5 centimeters is a lot. No? You can set back the mandible 2.25 millimeters, and then you can advance the mandible about 12 millimeters. Surgery to move the lower jaw back is more potential than the surgery that advances it. So you can move the mandible back more compared to you can advance the mandible. So the history, this orthodontic surgery, they start in the first half of the 20th century, means 1950. And they first developed the bilateral sagittal split with BSSO. It's quite famous, and by this surgeon. And it's 1959. Then after that, they improved the surgical technique. Then we have Rafford 1. Rafford 1 is even involved the alveolar process, and Rafford 2 involved the other jaw structures. In 1980, the movement was ideal to both jaw and the chin in all 3D plan. So later, initially they cut the jaw one piece. One piece, maxilla mandible, they moved it forward, backward. Then after that, then they cut the jaw in a few pieces, so you can move the jaw left and right or expand the jaw by doing the surgery. But of course, the more pieces you cut the jaw, then it becomes more complicated. Then because of blood supply and all that, so a lot of time, the more pieces you cut, then the more risky the surgery is going to be. So you need a very good surgeon to do that. Then after that, we come to 1990, we have rigid internal fixations. Previously, all this surgery, after they're done, then they tight the upper jaw by doing these intermaxillary fixations. It means they tight the arch bar, then they tie the upper jaw and lower jaw together. Then the patient cannot open the mouth for about 3 months. Then the jaw will heal, then they open up the intermaxillary fixations. Then after that, in 1990, they come out with this screw and plate. Then they can fix the jaw internally. So by doing that, then the patient don't need this rigid intermaxillary fixation. So the patient can function straight away after surgery. So what's the indication for orthodontic surgery? The problem is too severe for orthodontic alone. So whatever cannot achieve by braces treatment only, then maybe you can consider surgery to add in to your treatment. So again, if you can settle with braces only, then no one will go for surgery. Just matter at the moment you tell the patient you need surgery, patient will feel scared. Of course, the first thing is there will emotionally impact, and second is financially impact. So this one, if you do in the government hospital, of course they're very cheap. If you do in the semi-government, which is UKM, UM, you consider semi-government, then a bit more expensive. If you do in a fully private setting, then it's going to be very, very expensive. So you not only consider emotional impact, you also consider financial impact to the patients. So if possible, then we stick to braces only. Then if braces can achieve the result the patient want, then maybe we consider surgery accordingly. So the first indication, usually for the severe skeletal discrepancy, it means it's 2 class 2 or 2 class 3. Class 2 means the upper jaw stick out or lower jaw stick in, or either the prognatism of the upper jaw or the retronism of the lower jaw. It all can be both. Same for the class 3. Can the upper jaw too short, lower jaw too long? It can be the upper jaw is normal, lower jaw is too long, or can be a bit of both, a bit of both combinations. So second is a facial imbalance or asymmetry. One side is longer than the others. This one, braces cannot fix it. I mean, you have an asymmetrical jaw, braces cannot fix it. Whatever comes to jaw problem, braces cannot fix it. So I repeat again, braces can only fix the teeth. We cannot fix the jaw. That's a limitation for braces. So longer lower face, gummy smile, and all that usually treated by surgery. But recently, I think the last 1 or 2 decades, we have this what we call the mini implant. or the TAC, temporary anchorage device, which is a mini screw, they can do a bit better than the conventional braces. So we are talking about maybe we can do a bit more with the screw plus the orthodontic, maybe can achieve or mimic the surgical result. But there's still a limit, still a limit, how much you can do with this mini screw. So limitation of two movement, need to keep the teeth relatively upright in the bone. Like say the bone is a limitation, you cannot move the teeth out from the bone, be it maxilla or mandible. So you see the maxilla and mandible, the labial surface and palatal surface, or the buccal or lingual, that's a limitation, how much you can move the teeth. You cannot move the teeth out from the bone. So I know a lot of you heard about these Damon braces, which is they claim they can have to do extractions. You can expand the jaw a lot, but do bear in mind there's a limitation how much you can expand the jaw. If you're not careful, you push too hard or too much, the teeth might come off from the bone. It causes gum recessions, fenestrations, or sensitive. In long term, the tooth might not survive. So if in the future, if you graduated, you do a lot of Damon braces or whatever expansions, so do check your teeth is still within the bone or outside the bone. And number 4 is a potential relapse of the orthodontic treatment. So excessive or dental extrusions, then vertical elastic. A lot of time if you wear braces before, then you know we have to do a lot of rubber band, or be it class 2 rubber band, vertical rubber band, or intermaxillary rubber band, all cause this vertical force. This will extrude the teeth. So when it comes to extrusion, it's not stable. The expansion or tipping of the teeth also not stable. So I would say generally a lot of treatments, a lot of movement for braces, they are not stable. That's the reason why now we go for long-term or retentions. In fact, we're going for permanent retention. So we like it or not, braces always come with a retainer. Without the retainer, I would say everything is going to relapse. Just some relapse a bit more, some relapse a bit less. So we relapse more, then people go back the second time, third time for braces, wasting time, wasting money. So if you do braces, you do it once for all, and then you stick with the retainer for a long, long time. Of course, no one can wear the retainer for life, but the longer you wear it, the more stable the result is going to be. So you try to wear it as long as possible. Okay, so what's the step involved in orthodontic surgery? So step by step, of course, first you have to do your E&D, diagnose the case accordingly. Then you do a lot of investigation, x-ray the mold, then you come up with the diagnosis. After you diagnose the case carefully, then you plan the case accordingly. So there's a pre-surgical orthodontic, then usually we start the braces first, then followed by surgery. Then surgery, after that you continue the braces to tidy up everything. So a lot of people ask why they have to do the braces first. Why not do the surgery straight? So the reason why is when your teeth is crooked, so when people cut the jaw or the surgeon cut your jaw, then they don't know where to put the jaw because of the teeth cannot bite together. Then when the teeth cannot bite together, no stable bite, they don't know where to put the jaw. So of course, when the teeth are quite straight to start with, you can do surgery first, but not many cases. People do surgery first because their teeth are already quite straight. So there's I think the Japanese, they're quite good in surgery first. They're quite good in surgery first. Of course, surgery first, they're always more difficult sometimes because whatever left behind, braces can move the teeth only very limited. So whatever left behind by the surgeon, then braces have to deal with that. Then when braces have to deal with that, that's a limitation how much you can move the teeth. So I would say, I personally prefer to do orthodontic first, surgery later. Of course, some surgeons might disagree with this. So diagnosis, after you diagnose the case, then you go for a pre-surgical orthodontic, which means you start braces, straighten up all the teeth. Then after that, you do a new mold or do a new impression, then pull out, then do a mock surgery. The mock surgery, you just let us know how much you want to move the upper jaw and lower jaw, especially when you want to come to these simulations. The patient asks how my jaw is going to look like. Then after the surgery, then you can plan the surgery using this study model, or we call it snap impressions. And this study model, you can plan how much you can move the upper jaw and lower jaw. Then after that, then maybe you can use a computer software, or you can use traditionally, we cut the photograph, the upper jaw and lower jaw, and like chicken a puzzle, then we move the jaw, upper jaw and lower jaw, then it's how we come up with the simulations. Of course, you have to be very careful. So whatever you plan might not be the final result. So a lot of time you do over-promise the patient, that's how they look like. at the end of the surgery. So you can maybe more or less like this, maybe a bit different after the surgery. And so it's very dangerous. A lot of time, this computer software, you can plan the surgery perfectly, and when the result come out, it doesn't be exactly the same with the computer software. So you have to always warn the patients. So that's why I think in UK, they never give the software simulation result to the patients. So the patient cannot use the photograph after the software plan and to compare to the surgical result after that. Okay, then if you plan the surgery accordingly, let's say you want to move the upper jaw 5 millimeter, lower the lower jaw 10 millimeters, then patient happy, then you go ahead to plan the surgery doing the what we call the wafer or surgical splint. Then after that, the surgeon will go in to a theater and cut the jaw, then they perform the surgery. After they perform the surgery, they need to stabilize it. Like I say, traditionally they do this intermaxillary fixation, meaning they tie the upper jaw and lower jaw together. Patient cannot move together at all. Then they let the bone heal for about 3 months. But now we're more to the bone screw and the plate. So you can fix the jaw straight away. Then after that, they only use the elastic to try to stabilize the bite. So I think now patient can function straight away after the surgery. Then after that, when patient heal, usually after 1 month, then we start the braces again to start tidy up the thing. So a lot of time when we done the surgery, it doesn't mean the braces treatment is finished. A lot of time we have to wear the braces for another 1 year just to tidy up everything, make everything perfect before we remove the braces. So braces first, surgery later, then after that back to braces. So braces is always the last one to finish a case. So if the surgery is not well performed, then the orthodontic treatment, the orthodontic will suffer. Because there's a limitation how much I can move the teeth. I move the teeth by 1 millimeters, but the surgeon can move the jaw by 10 millimeters. So diagnosis, very important. They have to diagnose a case, whether they are surgical case or the orthodontic treatment case. So clinical examinations, including the general medical and then the evaluations. These are very important. Then social psychology evaluations. These are, I would say, very important also, but a lot of time we overlook. So the patient, what's the reason? What's the reason they want to do this surgery? Or what's the reason they want to do braces? You'll be surprised. Some people, they do braces just because they want to please their girlfriend, boyfriend, or husband, not because themselves want to do it. So they have to be very careful for these kind of patients. So in UK, sometimes the patient come because they have a broken marriage or a broken relationship. Then they blame it to their face because the boyfriend, the husband don't like, or the girlfriend don't like the face. Then they want to change it. So those kind of patients, I think you have to be careful. Even though you do surgery, the boyfriend, the husband, the wife not coming back. So those patients usually send for psychology assessment. So a lot of time in UK, this orthodontic surgery, we have a team to do it. Not only the surgeon and orthodontist, but we have a few extra assisting staff or panel to do it. Then one of them is the psychologist. They evaluate the patients, what's the reason want to do it, whether emotionally stable, and whether they're suitable for this orthodontic surgery. If you heard before, some people committed suicide after the orthodontic surgery. Why? Because they don't like the face after the surgery, cannot accept that. So you're very careful, very careful. Jaw surgery will change your face forever and permanently. So a lot of time people, after the surgery, they have to retake the passport photos and a lot of things, a lot of documentation, they have to do it, the new photograph again. Because they will look different. They will look different. Some will look almost similar, some will look completely different. Depends their upper jaw or lower jaw and how much you move the jaw around. And then after that, if you see the patients emotionally stable, psychology okay, everything passed, then you send the patient for evaluations, investigation, CAF, X-ray, PA, skull, or whatever letter CEF, OPG, whatever X-ray necessary, you do it. So you can do some intraoral PA if you suspect they need further investigation. The more detailed one, you do the intraoral PA. OPG, submental vertex, then Henry's photograph X-rays to look at the patient, the bone maturations, whether they are stopped growing. Because the surgery, you want to do it once for all. You don't want to do multiple surgery. So usually wait until the patient stop growing before you do the surgery. We do it too early, then patient will keep changing again. Patient will still growing. Then after that, you end up second surgery because the result will relapse. So usually for orthodontic surgery, we have to wait above 18 years old. Above 18 years old. Of course, you can do it after 20, 25, no problem. But you don't do it before that because the patient is still growing. And sometimes you want a bit more detail, you go for CT scan. And study model is almost compulsory for all the braces treatment, especially surgery. Surgery, we have to take a multiple models or multiple impressions. A lot of time we have to plan for the surgery to see patient whether they're ready for the surgery. So when we straighten the teeth, then we take the mold, then we pour the impression, then we have the model, then we try to articulate both models, see whether they can occlude nicely. If they cannot occlude nicely, there's something blocking, whether the cups are palatally inclined or buccally inclined, then we have to further detail or fine-tune the teeth position before the surgery. So when they are everything okay, study model okay, then only we send for surgery. So this one is a study model. I'm talking about study model. Study model is very important. So study model, when you get the study model, then X-ray, then the patient's clinical record, then you can plan the surgery case or the orthodontic case accordingly. Like this patient, on the top left, bottom, on the left picture, this one is a case. So this one, on the right side, is a facial asymmetry. You see the left one and the right one, they are not the similar length. Of course, then after that, you can plan the case accordingly. You can do the X-ray tracing, the calf tracing. Then you can see the upper incisor, lower incisor angle, whether the upper SNA, SNB, whether they're perfect or they're less than average. And after you get this evaluate, then you can plan the case accordingly. So surgical predictions. So you can predict the surgical result. So your predictions of the post-operative profile of the patient with some degree of accuracy by caphometrics. So you can use this X-ray. After you trace the X-ray, like let's say the upper incisor that are not perfect, then after you tilt the angle back by braces, then you can see the correct overjet and overbite. Then you can plan how many millimeters you want to move the upper jaw and lower jaw. By doing that, then you have this prediction. Of course, this prediction only have some degree of accuracy. They are not perfectly accurate. So they have to be very careful. Whatever we do is just draw the mock-up. It's not the final result. So osteotomy and extent of movement of orthotomized segment is determined on the tracing sheet. So we use this X-ray tracing, then we move the teeth around, upper jaw and lower jaw, then we come up with the final result. And traditionally, we use this tracing sheet because we don't have the X-ray. We don't have the digital software. So a lot of time we use this paper, semi-transparent paper, then we draw it with the different colors. Then we plan it with different colors. So let's say this one is red in colors, then we use maybe blue or green colors, then to plan for the surgical movement of the upper jaw and lower jaw. Then we use this paper, then they overlap each other. That's how we do the tracing. Then soft tissue and lips to follow the bone movement. This one is very dangerous. So a lot of times the software only can predict how much the soft tissue will move, but it doesn't mean you move the teeth back or the jaw back 2 millimeters, then the soft tissue will move 2 millimeters or so. Because soft tissue a lot of time they only move about 40 to 50% max, according to the research. So let's say you move the teeth about 2 millimeters forward, then the lips maybe will follow about 1 millimeters, 2 to 1, about that. So you have to be very careful. So whatever you do for the jaw movement doesn't mean the soft tissue will move according to the same ratio also. So this one, sometimes you have to be careful. So this one is typical surgical predictions. So you see they do the tracing, then overlap with the face, then they move the jaw around, then they predict the soft tissue maybe will move according to the surgical movement. See the soft tissue, this angle, ligamental fold will be a bit shallower. So you see just software predictions. Of course, this picture, you have to be very careful. So sometimes if the patient, after surgery, they see the picture is not exactly the same as the surgical result, they might question you why. So prediction is always prediction. It's not the final result. So surgical predictions, this one is 3D. So some now that I think they are more advanced now, they come with the 3D predictions. So I think this software called Dolphin, I'm not sure you're aware of that. Dolphin is a calf tracing software. They can do a lot of surgical movement prediction with this software. So in UK, they use a lot of Dolphin. Malaysia, I think is only Selayang Hospital have this software. But this software will cost you about 70,000, 80,000, just the software itself. So I think not many hospital or government body or the private body can afford this. So maybe Masa can buy one day. Let's see. So 3D software can be a CT scan or intraoral. You want to rule out any supernumerary, any extractives, delivery inside, or you want to rule out whether the short root, sharp, or maybe pipette root. Then this one may be prone to resorption or whatever reason. You can take a better X-ray, which is intraoral. So intraoral always give you a better detail compared to the big X-ray. So big X-ray, you take extraorally, there are so many overlapping tissue, soft tissue, hard tissue. So you want to look at one individual too, always it's good to take a PA, periapical. So this one 3D software, I'm not taking it very often because this one only the surgeon will want to look at sometimes the structures, surrounding structure of jaw. A lot of time we take only the calf X-ray, and then OPG, or if necessary, sometimes the frontal PA view, posterior anterior view. Okay, it's just look at the facial asymmetry. Okay, OPG, typical OPG. And wrist X-ray, like say you only want to look at the maturations of the patients. So you see this one joined together, means they're more mature compared to the left one, 7 years old, 13 years old, 18 years old. So you can see this, what you call, I think, interpharyngeal space is getting smaller and narrower. That means they are more mature now. So you look at this one, you know they're younger. Then this one, they're a bit narrower, the space in between this joint, and they're a bit older. So if you're working in government, a lot of time, then if you're working in Sarawak and Sabah, there are a lot of immigrants, illegal immigrants. Then the police or the prison department will send you the patients, then they ask you to determine the age. So you have to be very careful. Some are doing drug trafficking. And if you say they're above 18, then most of the time they're sentenced to death. So you have to do this heavy duty, but you have to determine the age carefully. A lot of times you do the hand wrist X-ray, then you do the OPG, then determine the age. Then you send it back the report, then they will charge the patient accordingly. So same this one, the what we call the cervical vertebra maturation is the same with this one. Similar concept. You can see this vertebra, C1, C2, C3, then is how they related to each other. See the shape will change. Initially become very flat, and slowly become curved. See this one become curved, and they are mature. So pre-surgical orthodontic duration usually about 1 to 2 years. I would say on the safe side, then you estimate about 2 years for the pre-surgical orthodontic. So durations 1 to 2 years approximately. And basically the concept is just to align the teeth. So you straighten the teeth so the surgeon will know where to put the jaw. So you have a nice occlusion and stable result. If the occlusion is not stable, then maybe after surgery, the jaw, to know where to bite, then it's not going to be stable. So to alignment within the arches. A lot of time, this pre-surgical orthodontic, we call it decompensation. If you notice, a lot of patients, they have class 2 or class 3 skeletal pattern. Most of the time, the natures already did what the best for the patients. A lot of time, they already have some dental compensation. So for example, the class 2, then the lower usually procline. Then class 3, then the lower incisor usually retrocline. That's the nature trying to get the best overjet and achieve the lip seal or lip competency. That's called the dental compensation. So surgery for braces, we have to decompensate. I mean, whatever retrocline, we have to procline it back. Then whatever procline, we have to retrocline back. So we show the true skeletal or true overjet. Then the surgeon can plan the case accordingly. So your alternation or coordination of the arch. Sometimes the arch a bit narrow on the upper, we have to expand. Then the lower is a bit too wide, then we have to narrow it down. So we match the upper jaw and lower jaw, the size, and incisor inclination. Like I say, if a procline in the beginning, then we recline it, then back to the normal inclination. Decompensation, this is the most important. So you adjust the incisor back to the perfect angulation. That's what we call decompensation. So fixed appliance with rigid rectangular wires in passive state just before surgery. So a lot of time we keep changing the wire until the rectangular wire, which is stainless steel wire, the size is 1925 or sometimes 2125, which is the maximum size of the wire. With this rigid wire, everything will hold in place before surgery. So you don't adjust the braces anymore before the surgery, because after the final impression, you're not supposed to move the teeth anymore. If you move the teeth again, then whatever the plan might not be accurate. Then the wafer might not fit in very well. So for intermaxillary fixation, the hook attached to the wires by soldering or crimping or bracket with a hook are used. So a lot of time after the surgery, then they need to do some intermaxillary fixation using the wires or maybe using the rubber band. So they attach multiple hook on all the bracket or on the wire itself. So the patient can attach the rubber band or the surgeon can tie the wires on it. So just before surgery, then a lot of time I'll put some hook in between the bracket, or sometimes I'll put use the bracket with the hook itself. So pre-surgical orthodontic lasts about 12 to 18 months. I would say maybe something up to 24 months. After the complete set of record are taken for the model surgery and finalizing the treatment plan. So pre-surgical orthodontic, estimate 1 to 2 years. So after you straighten the teeth, this one have some gap, not closing. You have to close the gap, straighten the teeth, and only they are ready for the final plan. So mock surgery. Mock surgery is very important. After you straighten the teeth, then you take a new impression again. So based on this impression, then the study model and the record and the new X-ray, then you do the prediction tracing and the surgical plan decided. And then the surgery simulate on the articulating working model. So you take the impression, then the mount on the articulator, usually a semi-adjustable, at least. Sometimes you use a fully adjustable. So it depends availability of the hospital. So after that, you plan for the surgery. So the model are cut. You cut the model, then reposition in desirable position, and the segments secure in their new position with a sticky wax. So you can see these pictures. So they cut the model, then move it forward, backward, up, down. Then after that, they glue it with the sticky wax. And after that, they fabricate the wafer according to this new position. So they do this surgical splint, or we'll call it traditionally called wafer. So this one is just to know where to put the jaw after they cut it. A lot of times they have 2 surgical splint if you have double jaw surgery. If you have single jaw surgery, maybe 1 surgical splint. So surgical splint are then constructed on the achieved occlusion or the planned occlusion. So after they move the jaw with the model on the articulator, then they do the surgical wafer or splint on this new position. So like say if the double jaw, a lot of time double splint, is single jaw, single splint. Simple. Okay, then after that we plan, then we present to the patient happy, then we go ahead with the surgery. So if you wonder, do the orthodontists have to go to the theaters to see the surgery? No, we don't have to. We plan together, then the surgeon will execute the job, surgical part. So of course, if you're interested with the surgery, you want to see it, then you go in the theater, then make sure they do a good job. But a lot of time we are not involved. So we send the patient off for surgical procedure, then we usually they take 1 to 2 months, depends whether they are student or adult. They need to take leave from work or from study. So a lot of time they wait, even though they are ready for surgery, they'll wait until the school holiday, or sometimes they have to apply from off from work until they get approval from the company. Then they go ahead for the surgery, which will take another few months to plan for it. So a lot of time this surgery case need a very detailed plan for the time frame and to the recovery procedure. So surgical procedure, a lot of time, then they are single jaw, sometimes double jaw, depends on the complexity and the severity of the malocclusion. So they cut the bone, then reposition the jaw back to the ideal position, then they fix it with the screw and plate. Or sometimes the old-fashioned, they do the IMF, intermaxillary fixation. So this one is a typical IMF, but using the rubber band. using the rubber band. That's why you see there's so many hooks around on the wires or on the bracket. So you can attach the rubber band vertically. So you tie everything together. Then you use the screw and plate to stabilize it. So post-surgical, after the patient recover, you stay in the hospital. After this surgery, they usually stay in the hospital for a few days until they are able to eat by themselves. So if you imagine they tie this jaw together, you cannot do the normal digestion of the food or the ingestion. So a lot of times they have to use this soft diet or the straw, or sometimes you have to use a nasal tube just for the food input. Then after that, when they recover better, they'll remove this intermaxillary fixation. Then patient can eat, then recover, they're better, no more pain, then we discharge. So when we go in again for braces treatment after the surgery, a lot of time we wait until patient no pain, recover well, can talk, can eat, then we start braces. So braces, no hurry, no hurry. You don't do the braces adjustment straight away after the surgery. No point, because the patient cannot open the mouth, then patient in pain. Why you want to cause more pain to the patients? No point. So you wait until the surgical procedure recover, which is usually up to 4 weeks. So active tooth movement is 4 weeks after the surgery. So a patient can come to see you, driving themselves, then no pain, coming by themselves, no one need to accompany them. Then they're comfortable. Then we start braces again. So the final stage of braces is a final detailing of the occlusions and the root parallelism. A lot of time the root is not parallel, then they'll just finalize, then the detail occlusion. Once some tooth will need extrusion, intrusion, so it just finalize the position and make the occlusion better. Then a lot of time you have to ask the patient to wear the rubber band, intermaxillary rubber band, and the round wires for interdigitations. A lot of time you see after surgery, the teeth is not biting together very well. They don't have this interdigitation perfectly. So we ask the patient to wear the rubber band, be it square, sometimes triangle, class 2, class 3, and to get the final perfect occlusion. So the rigid wire, like I told you, the rectangular wire before surgery, a lot of time after the surgery, we remove it, then I put a flexible round wire. So the teeth can move up and down a bit better, more flexible, better for the settling of the occlusions. So if the condyle are displaced during the surgery, wrong occlusion result, then may be corrected in the immediate post-surgical period. So you might think this surgery is very simple. In fact, it's very complicated. A lot of time, even the surgeon, the best surgeon cannot do it one time correctly. So after the surgery, if I notice the occlusion is far out from the plan, then we have to send the patient back to the surgeon. Then we have to do the second surgery before everything fused together. So you have a chance. If you notice the patient have a wrong occlusions, it's not what we planned, then immediately we contact the surgeon. We say, look, that's far out from what we planned. We have to go in the second time before the bone is fused after treatment. So you can take out the screw and plate and then reposition the jaw before they're fused together. So you have a chance to do it one more time. But we try not to. That's why we have to plan the surgery very, very carefully, very detailed, just to prevent the second surgery. But this condyle is very difficult because after you fracture the jaw, the condyle might not enter the fossa. So they might come forward, backward a little bit. So we try, the surgeon try to push the condyle back to the fossa before they plate or fix the jaw. But sometimes we cannot see. You cannot see whether the condyle is in the fossa or not. We can only guess by pushing the condyle back before they fix the jaw. But let's say it do happen after the surgery, the jaw is not biting correctly, it's still class 3, still class 2, or the bite is reversed, and asymmetrical jaw center line off too much, we send it back, second surgery. Cause second surgery, patient feel upset, but if you didn't do it, I can't correct it with braces. Like I say, braces remove the teeth in millimeters. Let's say it's more than 1 centimeter. There's nothing much I can do. Either you accept the not perfect surgical result or you re-surgery again. So you can see this one is a pre and post surgical result. So we usually have to take a new x-ray, superimpose, and see what we did is that what we planned. So this one superimpose of 2 x-rays is very important. Again, we don't do the x-ray originally. We don't overlap it together. we use a tracing paper. That's the reason why now we come up with a well-sophisticated software. You can do it digitally. We don't have to use traditionally use acetate paper, which is quite old-fashioned now. But if you don't have this X-ray software, you can always go back to the old-fashioned way, then just use the tracing paper, then overlap it together. Then you can know how much and move the mandible backward or forward or upper jaw, lower jaw impactions. So surgical option for correction of the maxilla. So if you want to correct the maxilla, pronatism or retinatism, then maybe you can do the Redford one. Or if you want to do expansion, you can do this SAPI, surgical assisted rapid palatal expansion, or zygomatic buttress release. They'll cut the buttress a little bit. So Redford one, you know very well from the surgical department. They just fracture up the upper jaw on the alveolar process. Most widely used because it's quite safe. You cut on the alveolar process, then you can move the jaw around. But if you see it yourself in the theaters, then they are not something very pleasant to see. If you have an ONF before, you study ONF before, oral entrance fistula, you think that's a big deal. When you see this surgery, the surgeon just cuts the jaw like nobody business. They basically just cut everything. You can see the nose, the sinus, then they don't move the jaw around. I've seen it myself personally, which is quite traumatic. So I think this surgery you have to consider very carefully. We do it only when necessary. Maxillar advancement, of course, you cut the jaw, you can advance the jaw forward, bone graft in the retromolar area. If you move the jaw, advance the jaw forward, then there's always a gap between the new position, the bone, and the old position. So you have to fill up some bone graft if the gap is too big. So maxillary setback, limited by posterior skeletal component. Segmental osteotomy after premolar extraction usually done. So maxillary setback, also, if you want to set the maxilla back or push the maxilla back, you have to remember there's always some structures that prevent you from pushing the maxilla back too much. It can be skeletal or the airway. So you have to know the limitations. So if you go back, just let me go back to the envelope. Okay, go for maxilla. Okay, so you see, you can advance the maxilla forward 15 millimeters, but you can always push back only 10 millimeters. So you can push back quite limited, but you can advance a bit more. That's because posteriorly there's so many vital structures. So there's a limitation how much you can push back. Is that clear so far? Am I going too fast? Oh, okay.
It's okay.
Okay, okay, all right, okay. Okay. Okay, so of course, there are level 2, level 3, which involves the base of skull fractures, and usually only for the mixed face advancement or craniofacial symptom. Let's say have the, like say this dysostosis or whatever, the jaw problem, the skull problem, they fuse together. Sometimes you have to break the whole face or the whole skull, then to move everything. So surgical procedure can be maxilla only. When you want to do some expansion, then you just cut the palatal sutures and release a bit of buttress, then you can expand the jaw a bit better, especially when you already fuse sutures. So these are level 1 fractures. As you can see the top left picture, this is level 1 fractures. After you fracture, you cut it close to the nose, sinus. Then after that, they move jaw around. Then they fix it back with a plate and screw. Of course, you can do maxillary advancement. You move the jaw forward, you got advancement. And you can impact. Impact, it means you move the jaw upward. Upward, you got impaction. Then, of course, you can do segmental osteotomy. Segmental, it means you cut the jaw into a few pieces. Usually 2 or 3 pieces, depends. Sometimes premaxilla 1 pieces, then left and right, posterior maxilla 2 pieces. So 3 pieces. So 3 pieces, of course, you need more and screw and plate to fix it, and they're more complex. Then open bite, you can impact only the posterior segment. After you impact the posterior segment, then the upper and lower teeth can touch together a bit better. That's how we settle the open bite. Same. Now, if we use mini screw, we can mimic or simulate to the surgical movement. We put the screw on the posterior. We can intrude the posterior segment. Then we can improve the open bite. Maybe you can look at some cases later. So we can do maxillary advancement, bring the upper maxilla forward, upward, downward is not here. Okay, or selectively only posterior. So that's how much you can do with the left one. So posterior crossbite, a lot of time for class 3 patients, they have a narrow upper arch. So you want to expand a lot. But you know, if the suture is already fused, the mid-palatal suture already fused, whatever we do is just tilting the upper jaw buccally. So usually the palatal cups will hang down, or you call it flaring. So you want to do the true expansion, you have to split the sutures. So when the patient is still young, usually before 10 years old, you can easily split the sutures by using this RME, rapid maxillary expansion. By doing that, you can split the sutures, you can create a median diastema. That's what we call the true expansion. So when this suture is already fused, which is adult patients, you want to expand the jaw a lot, and a lot of time you have to break this suture again. That's where this surgical assisted rapid maxillary or palatal expansion will come in. So they use the surgeon will come in and split the suture or create a cutter, and they help your expansion. So for patient more than 15 years old, most of the time palatal suture is diffused, and this surgical procedure will come in. So surgical release of the zygomatic process, Referred 1, perform expansion after down fracture of the maxilla. So sometimes if you want to expand a bit more, you can do Referred 1 fracture also. So typical, this one, SAPI, SAPI surgical assisted rapid palatal expansion. So you put an expander, and the surgeon split the suture and plasters a little bit, then you can expand the jaw quite a lot. So the crossbite can be corrected. Of course, temporary will cause some median diastema, but this one will close. So what is the mandible? Mandible option, there are usually 2 or 3. So the first one, very common, we do BSSO, bilateral split, surgical split osteotomy. It means you just split both sides. Then using the BSSO technique, then you can move the jaw backward, forward. So vertical ramus, not very common, but there are some people prefer this. Genoplasty, if a double chin, short mandible, then a lot of time they perform this genoplasty. Or sometimes class 3 patient, they are too prominent mandible or the chin, then they will cut away the chin a little bit. So genoplasty, modify of the chin. So BSSO, bilateral surgical split osteotomy, the most preferred approach. So most commonly used by the surgeon in Malaysia, I think it's BSSO. Most preferred approach, so oblique cut, then from the ramus to the body, allow the broad interference of overlapping segment of the bone plating. So imagine, you see this surgical split like L shape, then from this ramus then to the body, and like L shape also. So you can move the mandible forward a lot, but this portion is still overlapping. This portion is still overlapping. So by using this technique, you can advance the jaw quite a lot. So mandibular advancement and setback can be done. So you want to step back, you just cut away these pieces, then you can step back. You want to move forward, then you just move the jaw forward, then fix it with the plate and screw. Then this gap will be filled up again with the new bone. So good control of condylar segment, but maybe cause damage to the inferior ID nerve. So you see the ID nerve on the top right corner. These pictures, they show where is the insertion of the ID nerve. So when the surgeon cut, they try to avoid this ID nerve. But because the cut is really close to this ID nerve, and you see from the front part, this ID nerve is run into the mandible. So when you do this L-shaped cut, maybe sometimes they will hit the ID nerve. That's where they cause damage. So a lot of time people will have this temporary numbness on the lips, the tongue. That's very common. They'll recover. If injury, they'll recover. But sometimes the numbness or tingling sensation will follow you for life. That's about 10 to 20%. They might have a permanent numbness. Not completely numbness, but tingling sensation is very common. Although some surgeon will tell you maybe just 5%, or some say in my hand it never happened, but it do happen. Go for the research. Researcher always tell the truth. So BSSO potential correction, you can advance the mandible, you can bring the mandible forward, or you can step back the mandible, bring the mandible backward. So if the mandible too short for class 2, bring it forward. Class 3, too long, you bring it backward. You see, after you bring it forward or backward, there's still overlapping between the cut. So you can always make sure there's a good blood supply between the two pieces of bone. So from top view, you can see how they split it like L shape. So the insertion of the ID nerve is in the front part. Because this ID nerve, it will go through the mandible, the body of the mandible. This cut sometimes can touch the ID nerve. Of course, they try to avoid that. But a lot of time, this fracture might not happen ideally in L shape. A lot of time, they happen fracture in the few pieces or the fracture not on the right position. That's where the problem will come. Sometimes they put the plating, they're not able to plate it very well because the bone is already fractured in a few pieces. That's why they cause a complication for surgery. They have to redo it again. So vertical subsigmoid osteotomy is the full thickness of the segment. Very simple. Vertical, it means you just cut the bone, not L-shaped. They cut it vertically. Of course, they cut it avoid from the ID nerve. So this one, they come down. This one is a coronal process. So they cut in middle, but behind the ID nerve. That's how they avoid the damage to the ID nerve. But usually only for mandible setback. So imagine if you cut this vertically, you want to move the jaw forward, you create a gap between it. How are you going to fill up this gap? So if you're lucky, the bone will fill back. If you're not lucky, it will cause what we call the sequela, is it? The dead space between the bone. So usually, that's why we say we prefer the surgical split technique, because they're overlapping between two pieces, then the blood supply or effusions or healing can be better. Compared to this vertical subsigmoid, they are cut jaw vertically, which the blood supply cannot be guaranteed. So usually if you move the jaw back, step back, then these two pieces of bone can be overlapped. So the healing will be better. So less chance for neurosensory damage because they are not cutting L shape. So you totally avoid this ID nerve. So the damage to the ID nerve, the risk of damage to the ID nerve is less compared to bilateral split surgical technique. So condyle segment control difficult. After you cut this, how are you going to make sure the condyle is in the right position before you split? Before you split it back. So how are you going to make sure this condyle is in the right position? Because it's so small portions. So sometimes difficult to control. So genoplasty just means changing to the chin or the jaw, the tip of the lower jaw. So the wedge-shaped segment of the bone as a symphysis can be moved in all three planes. You can move it left and right, up, down, whatever you want to do with this genoplasty. So you just cut the chin away, then you can move the chin forward, downward, upward, downward. So in AP or vertical plane, augmentation, reduction, genoplasty. You can add, or it means they bring the chin forward, or you can do some reduction, it means they bring the chin backward. So maybe done combined with the surgery. Sometimes you can do it as an adjunct procedure to the orthodontic surgery. So you just make the chin look a bit better. So add-on surgery. Or you can do just as an individual procedure. So you can stand alone. So some people, after they do braces, they still have the double chin. Then they go for this genoplasty only, without the jaw surgery. Can be alone or can be adjunct procedure. So you can see this picture very simple. They just cut the chin away, then they move it forward. So you get a bit more chinny. So this one, after that, they stabilize it with the screw and plate. Segmental osteotomy, not very common. So to reduce the vertical height of the body and maxilla. So you can cut away this segment, then move it upward. Then you can reduce the gummy smile. Same for this one lower. It's not very common, because this one usually for intrusions. Extrusions, you have to be very careful. Distraction osteogenesis. I think this one is one of my classmates is very expert in this osteogenesis distractions. I think Professor Fidaus. I think he is the master in Malaysia for this distraction osteogenesis. You can go to look for his research. So basically, they have the distractor. So they fracture the jaw, then put the distractor. Then use this distractor. This distractor basically is a screw. Then keep turning the screw gently or slowly. Then hopefully the bone will fill up this space. So orthodontic surgical movement is limited by the soft tissue. A lot of time, that's how much you can move the jaw back. Even though just now I showed the envelope, you can move it back 25 millimeters is 2.5. But sometimes if the jaw is too short, way too short, then maybe even though orthodontic surgery cannot fix it, then maybe they are thinking of these distractions, osteogenesis. So in craniofacial symptom, a lot of the apex, whatever craniofacial symptom with a skeletal severe skeletal deformity, then distraction osteogenesis is useful to achieve the drastic extent of the bone and the soft tissue movement. So this one, they move the jaw very slowly. So the soft tissue can adapt to the new environment better compared to the orthodontic surgery, which is drastic movement. So sometimes the soft tissue a bit difficult to cope with that. Your tongue, your lips, sometimes you have to adapt to a new position. It takes time. Compared to this distraction, because they move the teeth very slow, they move the jaw very slowly, so the soft tissue can adapt to it better. So they're only useful in the growing children before orthodontic surgery. Sometimes if the orthodontic surgery is the orthodontic surgery might not correct the full extent of the skeletal discrepancy, then maybe you use this orthodontic distraction or the osteogenesis to reduce the severity first. They only go for the surgery. So sometimes if you're lucky, you don't even have to go for orthodontic surgery. You can use this distractor and to achieve the result you want. So they usually work better in the growing children because the wound healing is better, then the bone regeneration is better. So the bone fracture intentionally, it means they fracture the jaw on the purpose. If you didn't break the jaw, how are you going to distract the jaw? So you have to fracture the jaw first into two segments. Then I join these two segments with the distractor. Then under the slow traction and tension, then the callus or the new bone will form at the osteomized end or the end with the corresponding soft tissue regenerations. Then distraction, orthogenesis, and histiogenesis. Histiogenesis is just differentiation to the specific organ or the tissue with the purpose. So you can see this, there's usually for the lower, lower. Then they put the distractor. Then the distractor, you can turn the distractor maybe every day, then slowly they will advance the jaw forward. Okay, so we talk about so many types of surgical movement. So which one is more stable than the others? So you have to know they are still prone to relapse even though we do surgery to advance the jaw, then impaction, whatever you can do for surgery. There's still one problem for braces, relapse. Relapse is always the biggest problem for orthodontic treatment. So the most stable is the maxillary impaction, mandibular advancement, class 2 patient, advance the mandible forward, genoplasty, any direction is stable. So the less stable a little bit, then follow the chart going down. So the second one is maxillary advancement, correction of maxillary asymmetry, then stable, really rigid fixation. Impaction, mandibular advancement, maxillary advancement with mandibular setback. Problem one. So you look at the problem one. What's the problem? Not stable. Correction of maxillary asymmetry. Why? Because there are muscle involved. The masseter muscle is a very strong muscle. All the time, even you correct the jaw, the muscle is not corrected. You still have a stronger muscle on one side. So in long term, they will relapse. Patient will come back into you and say, why my jaw is still not symmetrical after a few years? Or they come back the problem. So are you going to break the jaw again, then do a second jaw surgery? Then you have to think twice. So least stable, the least stable one is the mandibular setback. A lot of time class 3 patients, after surgery, many years later, then come back with a class 3 again, reverse overbite. Then are you going to do a second surgery, third surgery? Then you have to think carefully. Maxilla downward, so downward you fracture, you move the mandible downward, that is less stable. Surgical expansion of maxilla, this is also less stable. So relapse could be due to the surgical factor. Surgeon is not good, maybe. Just kidding. No, there's other factor. Planning extent of movement, not accurate. The plan is always the most important thing for surgical orthodontic. If you didn't plan correctly, then the surgeon cannot perform precisely, then the surgical result not stable or not good. Extractions of the condyle. I said the condyle is movable. So before they fix the bone with a screw and plate, you have to push the canal back to the fossa. If you fix the jaw, when the condyle is out from the socket or out from the fossa, then the result is not good because once the condyle moves back to the fossa, then the result will change. So inadequate fixation, it means the screw and plate is not enough, or sometimes the rigid fixation is not good, then the jaw is still movable. Then you have a non-union healing. Then you go back to fix it again. So orthodontic factor, it can be the teeth is not in the equilibrium zone. So for braces treatment, a lot of time we're talking about this zero zone or the equilibrium zone. They mean the teeth is in the equal force. So if you see the teeth, then in the middle, so you have a buccal cheek, and then lingual you have your tongue, and then in between the teeth you have these ligament periodontiums. All these factors will play into this equilibrium zone. So if you put the teeth in the zero force between the buccal and lingual, then the teeth will be stable. So if your tongue is stronger, then maybe you push the incisor forward again. If the lip is stronger, maybe you retrocline the upper incisor or lower incisor. So this one quite difficult, huh? So even the orthodontist maybe cannot achieve this zero zone or the equilibrium zone. So we only can try. Huh? The extensive of the tooth movement, the more you move the teeth, then the more prone to relapse. Huh? The more you move the teeth, the more prone to relapse. That's why a lot of severe crowding, I always recommend long-term or permanent retention. Big gap, permanent retention. The more you change it, more extensive the retention, or the longer the retention period is going to be. Patient factor. So the severity of the condition. Maybe patient present with a very severe skeletal discrepancy. It can be due to the cleft palate with the scar tissue they repaired before. So if the patient have the surgery done before, there's always the scar tissue, the limit how much we can change with the braces and surgery. So the scar tissue for the cleft patients, after you repair, they form the scar tissue. The scar tissue will limit the development of the maxilla. That's why this cleft patient, when you notice, they're always with the small maxilla or underdeveloped maxilla. A lot of time it's due to scar tissue from the palate and from the lips. So scar tissue, you cannot expand very much, or you cannot bring the upper maxilla forward too much because scar tissue is not movable. They're very fixed and rigid. Okay? Persistent habit, let's say you have your favorite is infantile or swallowing or reverse swallowing, then you keep pushing the tongue forward, and even though after surgery you can bring the upper maxilla backward or extrusion. Then if the habit persistent, maybe this open bite will happen again, or maybe you have a finger biting habit and open bite will happen again. So habit can be a problem, huh? And correct tongue position and the correct swallowing, then it's very important. Poor compliance with the treatment. So if patients after the treatment, they cannot wear the rubber band very well, then they will not get the result they want. Okay, so I think we finished everything we want to cover. So I think now we open for questions. Are you all still there?
Yeah, still here, doctor.
Okay.
There's a lot to take in.
A lot to take in,
Yeah.
Because this surgical orthodontic is considered the advanced level for braces. So don't worry, I know there's a lot of information to take in today, but what I'm trying to say is whatever you cannot achieve by braces, there's always a surgeon to back you up. So it's always a surgical option, because if you're trying to be a hero, then you want to move the teeth too much, then it might end up the teeth might come off from the bone. You might not believe, but it actually happened. Yeah. Okay, questions?
Doctor, sorry, don't want to
Yeah.
ask. The corticotomy, right? You were saying about how's that?
Okay.
Yeah. You were saying that it's called the trauma to the bone, basically to accelerate the bone
Yeah.
movement, right?
Yeah, good.
Then when is the indication for this? I mean, is it like when you're trying to do conventional braces and then the movement is not rapid enough?
Okay. All right. You see, this initially it's I think invented by this Wilcox brother. Initially the procedure called Wilcoxotomy. So Wilcox brother invented this. Then they make a small cut on the bone. Initially they only use the piezo cutter, very precise. So they do a cut in between, interproximal, in between. Every single tooth they make a small cut. Then they cover it back with a flap. Then they notice the teeth can move twice faster compared to conventionally how we do braces. So why not we move the teeth faster if we can do it? So that's the whole concept behind it. So you see, whenever you have an injury, you have a bone turnover which is faster. Because you have inflammation, you drag this, osteoblast will come into place. That's why the bone remodeling is faster. So when the bone remodeling faster, then that's how you move the teeth faster. But the problem is, the bone will heal after 3 months, isn't it? So the effect after 3 months is already diminished or is already back to zero. Are you going to cause another surgical procedure to the patients? Maybe not, because this is considered invasive procedure. So now they come up with a bit more gentle procedure. They have this micro procedure. They are not open the flap. They just use this plate to cut in between the teeth. Cut between the teeth. Again, they're causing trauma, but not too much of trauma. They cut between the teeth, and they attract the more osteoblast or osteoclast. Again, they can move the teeth a bit faster. But this effect, again, after a few months, will diminish or they will go off. Then you have to repeat the same procedure again. So this procedure is only for patients who don't have time. Then they want to be fast. Conventionally, braces, we do it for 2 to 3 years. And patients say, I want to do it in a few months, 6 months, 9 months, 1 year. Can you do it? Yeah, we can do it. Yeah, by doing this corticotomy. But you have to remember, whenever you raise a flap, then sometimes it cause a gum recession. Then second thing is you drag more osteoblast, whatever class, then that will damage the root further. You have to remember, the faster you move the teeth, then the shorter the root is going to be, maybe. So I personally not favor for this corticotomy. But you want to do it, you have to do it with with precautions.
Okay. The one you were saying, the inserting a plate at in the dental, is that classified as corticotomy as well?
Inserting a plate,
No, the one you were saying alternative to this,
No, I wouldn't say that it's corticotomy, but they are not inserting the plate. They are not only cutting the soft tissue. They use a hammer to whack this plate into the bone. You know, like you're nailing the screw in. They just whack a little bit the plate into the bone, then they take it out. Then every single space, they just do the same procedure. That's still considered corticotomy. Corticotomy means whenever you touch a bone, consider corticotomy. Even though you are flat or flapless. So now they come up with this micropunctures machine. They are pulsating machines in and out with a sharp needle. They touch a bone very gently also. They are doing a micro perforations on the mucosa and the bone together. Invented by this professor from America, is a Korean, I think Kim or something, I can't remember. So they are doing the same thing. So the basic concept behind it is just cause trauma. Then hopefully the trauma inflammation will bring the teeth movement faster. That's the concept behind it. Any more questions?
Doctor.
Sorry, let me go.
Okay.
Sorry, are we expected to know precisely in terms of millimeter of the envelope of discrepancy?
No, I don't think so. Yeah,
we just have to know the concept of three, like the three envelopes of conventional ortho plus growth modification and surgical.
I think you don't have to memorize these figures. You don't have to. But you just have to know the concept. There's a limitation how much the braces can do. You can do a bit better with the braces plus the growth modification. Of course, some severe case, you have to do surgical.
Doctor, also one more thing about this envelope, right? The center of this whole envelope, is that the ideal location or is that my starting location? I'm a bit confused which one is. Like
which one?
Like
I didn't get it. Yeah.
Like okay, the maxilla right now, right? At the center, that tooth.
Yeah.
Is that the final position or is that the initial position? Like let's say this tooth I want to extrude, right? So extrusion is
Yeah.
2 millimeter,
Yeah.
or it's 4
This one
millimeter.
is the final. Extrusion is a 2 millimeters. Sorry, extrusion is 4 millimeters. Intrusion is 2 millimeters. So this two is a final position you want to get. Let's say this one's 7 millimeters. It means you can bring the tube back 7 millimeters. So, okay, let me see. I can get the, okay, this one's better. So you see this one, the left top corner, there's how you move the teeth. This one move the teeth forward. This one move the teeth backward, downward, upward. So you look at this envelope. This one is a final position. The middle one, the middle cross is the final position of the teeth. So you can move the teeth up 2 millimeters. Intrude the teeth 4 millimeters. That's the envelope. So same for the maxilla. Maxilla, you see this one. You can extrude the teeth 4 millimeters, intrude the teeth 2 millimeters. So this middle one is the final position.
Okay, understood. Thank you.
Yeah.
Doctor.
Yeah, go ahead.
I don't quite understand the surgical spleen part.
Okay, good question.
Is it for like a template, sort of a template for guidance during surgery, or?
Yeah.
Because I was wondering if there's an IMF there, and then how does that work?
Yeah. So you see this wafer is for the surgeon to know where to put the jaw. So imagine, okay, all right. Okay, so imagine if I cut the upper jaw, then I don't know where to plate or put the jaw, because this jaw is mobile. You don't know you're going to put the jaw backward, forward, upward, downward. So you use this jaw to fix it to the lower surgical spleen. Because this surgical spleen with a T bite mark on it. So when you cut the upper jaw, you just put the jaw on the surgical spleen or wafer, then they will fit nicely on the wafer. Then you put the screw and plate on the jaw. That's how they fix it. So this one for single jaw. Let's say you cut the upper jaw, then you attach the upper jaw to the wafer, then you plate or the screw on the upper jaw. Let's say you're going to cut the lower jaw. The same thing. You need a new wafer, then where do you put the lower jaw? After you cut the lower jaw, then put a new wafer, then you know where the lower jaw should be positioned according to the new position of the upper jaw. That's why I say the upper jaw or single jaw, one wafer, double jaw, double wafer. Can you imagine? Okay, let me just see. I can get these pictures. Okay. So for example, these pictures, I want to do mandible setback. Okay, I want to set back the mandible. After I cut this mandible is mobile. How will I know how much or how many millimeters we are going to bring the mandible back? Because this one I have to do it according to the surgical plan. So I put a wafer attached to the upper jaw. Then I use this movable lower jaw, then bite on the wafer. Then I know where to fix the lower jaw. That's how the wafer works. Yeah?
Okay. Then the IMF is after.
IMF, we don't do it very often now, because now you can do this internal fixations.
Okay.
Yeah. This IMF, usually during the surgery, yes. Because after you use the wafer, then you have to tie everything together. So after you tie everything together, fix everything together, only you put the screw and plate to fix the jaw.
Okay. So the spleen is part of the IMF.
Yeah, it's part of the IMF.
Okay, got it.
Now, after you fix the screw and plate, you can remove the IMF almost instantly after the surgery. Compared to last time, we only take it out after the bone is healed.
Yep. Okay, got it. Thanks. Thank you.
Questions? No? No question.
Doctor, sorry, one more. The Henry's radiograph, right? You were saying about the criminal implication, right? About the age. But other than that, is there other use, like clinically?
Clinically, of course, you have to make sure the patient stop growing. The ones are clinical, the criminal, the age modification, that one is our topic. It's not today's topic. But if you're working in a government clinic, sometimes you get this case. But what I'm trying to say, you have to make sure the patient is stop growing. Then we take this Henry's photograph or whatever photograph. X-ray. We just see whether the patient is already mature enough to do the surgery.
Oh, you mean sometimes even there's patient who is like considered mature, like 18 or 20 years old, but the Henry's still shows that they're growing, is it? Is that?
Yeah, possible. Because chronicology maybe is different. Huh? So you don't base on the age, but based on the X-ray.
Okay. So it's more of a confirmation sort of a radiograph. Okay, understood.
If you see the patients, throughout years for braces treatment, then you see the patient is not growing taller, then you know they are already stopped growing. So sometimes beside this, you can measure the patient height, then the shoe size, and if they're not changing, I think more or less they're stable. Because you can double confirm, expose the patient to more X-ray. Yeah. More questions?
The surgical prediction falls under diagnosis phase, right? Not the mock surgery, right?
The surgical prediction is mid treatment replanning. Of course, you can use
under mock surgery.
Yeah, under mock surgery.
The first
diagnosis before we start braces, you can do the mock surgery, but not very accurate because the teeth is not straight. Then the angle of the incisor might be changing. So usually mock surgery only come after the pre-surgical orthodontic. After you straighten the teeth, everything in the final position, then you can plan the surgery better. That's why I'm not supporting this surgery first concept, because risk the teeth might move again, so they are not the final position. Compared to if you do the pre-surgical orthodontic, you fix everything, that's the final position of your teeth. You're not going to change it anymore. Then the mock surgery or the surgery will be more precise. Yeah. Any more questions? If not, then we look at some cases for surgery, surgery cases. Okay, so for example, this cut 3 camouflage, we use braces only. A lot of time we tilting the teeth back. We're changing the upper and lower incisor angle. So upper we procline, lower we retrocline. That's how we fix the reverse overbite. So the more severe the lower jaw, longer, then the more tilted the teeth is going to be. You see how much you tilt the teeth back. So even though maybe you can see you fix the bite, but you're not fixing the jaw. So this is also same thing. You can reverse the bite. You see how much the lower incisor lean back and how much the upper incisor procline. You fix the bite, but you're not fixing the jaw. Same thing. Of course, they'll look straight at the end, but the jaw is still longer. So whenever come to jaw, patient not happy with the jaw, maybe surgery would be a better option. So same this one, you fix it. You see how much the lower incisor lean back. Okay, so when it comes to surgery, it means there are severe cases. So this one, you see how much you can lean back the lower incisor. You're not going to lean back the incisor about 45 degrees. Upper incisor 45 degrees is going to make it look worse or not natural. Or even you try sometimes might push the root out from the bone. So this kind of case, we do surgery. Of course, you do the pre-surgical, straighten the teeth, or sometimes make it look worse. Then after that, you set correct with surgery. You see how much we can change the face. They will look totally different person. So from the class 3 to almost class 1. You see the eye also different now. The patient look more confident. So you see this one, surgery case. So one concept is you have to make sure the patient is looking better after the surgery. If not, then no point going through such a complicated procedure to make the patient suffer and they're not happy with the result. So treatment only to improve the patient quality of life. If not, don't do it. Don't do it. Asymmetry, similar. So let's say it's a discrepancy between the upper and lower jaw. The lower jaw is not symmetrical. And you see the midline discrepancies is a lot. Then have a crossbite on the right side. So this one, you do the jaw correction by splitting the splitting the lower jaw. Maybe you cut a bit more on the left side, so you can shift the center line back to the center. That's how much you can correct, Joe. Okay, I think if no questions, I finished today's lectures. Any more questions? Oh, Clef is next week. Any more questions? If not, then sign your attendance. Then I'll see you next week. Yeah. You have your case discussion with me, is it?
Okay. Thank you, Doctor.
Okay. I think if you have a case discussion next week, I think we are going to look for this case. This case. No, not this. Maybe we go for this. Okay. So we do the second case, maybe? Have you done the second case? This case?
Not yet.
Oh, yeah. But Dr. Pratap already did the first case.
Yes.
Okay. So next week, I think the case discussion, we discuss this case. Has-3 scatter pattern. Then it's more relevant to today's orthodontic, surgical orthodontic. Okay?
Okay.
Okay. All right. I'll see you again. Stay safe.
All right. Thank you. Thank you, doctor.
Bye.
Doctor.